So my name is Ryan Swires. I'm a consultant in public health. I work for South Tyneside and Sunderland NHS Foundation Trust in the North East of England, and I also work on behalf of the North East North Cumbria Integrated Care Board. If we can just a little bit of housekeeping, these will be things that you're familiar with. If you do have questions, then please try and use the chat function. We will come back to any questions that we're not able to pick up during the session afterwards. We'll do our best to stay on top of them, and we will have some time throughout the session and at the end to pick up questions, but anything that we're not able to pick up because of time, we will come back to people afterwards. If people need to take a break, it hopefully goes without saying, feel free to do so. Likewise, if you're able to and you want to, get up and move around. We are going to be here for a couple of hours. All of the slides will be shared afterwards. So speakers' presentations will be shared afterwards, as will the recording of this. So don't worry too much if you're scribbling notes down and you don't get them all. And if you do have any technical issues during this, if you're having any problems accessing any of it, then Yo-Yo's email address is on there, and Yo-Yo will be more than happy to try and help. Okay, so kicking us off today is Professor Bola Olabi, who is the Director of the National Healthcare and Equalities Improvement Programme. Many of you will have seen and heard from Bola before, but we're really pleased that Bola's going to open things up for us in today's webinar, and so I'll hand straight over to Bola.
Thank you so much, Ryan, and I hope colleagues can hear me. It's wonderful to be back. I don't know what the rules say, but if there are colleagues who are able to switch on their video, that would be wonderful. You'll have to forgive me. I'm an extreme extrovert. I do need people, and I say that unashamedly. So if people don't mind switching on their cameras, it would be just wonderful, to see the colleagues that I'm talking to. Thank you so much. I can see some of you popping your cameras on. That's excellent. Thank you. And I hope that I don't end up crashing the Teams meeting as a result, because there's nearly 550 people on the call. But look, good afternoon. It's wonderful to be back with you all again. And I start actually my conversation with you this afternoon with something very fresh on my mind about the power and the importance of us actually understanding one another. Mindful of your time, but I think it's really important to share this with you. I have done with members of my immediate team within NHS England. And, traveling back from one of my speaking engagements in London on Wednesday night last week, and suddenly hearing this announcement go out on the train between London and Sheffield, which is where I was trying to get to. Is anyone medically qualified on this train? Please, can you make your way to Coach B immediately? We have a medical emergency. Found my way around to Coach B to find that somebody had become unconscious, and how powerful it was to be able to talk to the people around them to understand what had gone on, so that I could understand the history. Really pleased to say that, they did come round. We did manage to stabilize them and hand them over to people over in Chesterfield who could help them. But I'll tell you this immediately, that the thing that helped me more than my medical knowledge or my medical skills and capabilities was the ability to understand what this young man was saying to me, and what I was saying to him, and what the people around us were saying to me. That information was so invaluable in the decisions that I made after that. That's literally last week. So I come fresh into this conversation with a greater determination that actually health literacy matters. It really absolutely can be the difference between life and death, whether or not you understand what is being said to you, or you are able to communicate what you are trying to say. So if I go on to my next slide then, please. Thank you. And the reason that I've shared that story is because sometimes when we talk in the language of health literacy, digital literacy, sometimes we can get lost in the policy and the strategy way of talking about these things. And I just mulled over sharing that story with you. And I thought, you know what, I'm going to share that story because I think it brings the humanity back into the conversation. So when we talk about health literacy, what do we mean? I think it's a two-way street, really. There is the bit about people understanding what we're saying, having access to the information, understanding the information, being able to actually really look at that information we're giving people and make a decision about the offer, whether it's in terms of care or service. Certainly, that's what the World Health Organization tells us. But I really think the opposite side of the definition is just as important, i.e., the importance for organizations to understand that the complexity of how we are organized is part of the health literacy question. So it's not just up to individuals and communities to understand. I think it's really important for us as healthcare systems to also understand that we can be quite complex and we can be quite difficult to navigate. And I think, therefore, there is something about how we enable people and communities to understand us better. And there is a role for us as healthcare professionals, services, and systems to think carefully about how we organize ourselves and how we put ourselves across to the people who are trying to use our services. So it's absolutely a two-way street. On the next slide, then, thank you. I just quickly want to talk about, why all of this matters. And next slide, thanks. It's just thinking about, so why should we care? Now, this slide is not telling you anything new at all. This actually is something that a GP colleague, Dr. Tudor Hart, working in the Welsh Valleys, told us decades ago. And he coined the phrase, the inverse care law. And the thing that is very striking for me is that fast forward all of these decades since Dr. Tudor Hart first made this statement, we have Lord Aradazi saying the same thing last year, decades later, that actually those in greatest need tend to have the poorest access to care. And that's essentially what we mean by the inverse care law. And that inverse care law persists not only in terms of people's ability to access care and services, but also, as I've just been saying earlier on, in their ability to understand what it is that we're trying to communicate to them half the time. So sadly, 5 decades on, the inverse care law still applies. On the next slide, I'm going on to talk about and why we do need to start making some inroads in this area. There are a number of levels of the cost of health literacy gaps. There is the cost in terms of the individual, there is the cost in terms of the community, and actually there is a cost for the NHS as well. And that's the thing that I just want to spend some of these slides talking about. So we know, for example, that 4 out of 10 people actually struggle to understand health information, especially when we use written words. We know it's not as easy for people to immediately grapple with that. And I was reading an organization's strategy on the train from Sheffield to London this morning, and it was all in beautiful colors and diagrams and pictures. And I thought, even I can understand this far better than if they just put it in terms of themes and the way we tend to set things out. So we know that 4 out of 10 adults, this is not children and young people, adults, struggle to understand when we put our health information in a way that contains words, particularly the written word. And we know that it's 6 in 10 who struggle to understand when we then combine those words with numbers. It gets even more difficult. And that's why I'm deliberately not talking about percentages and quintiles. I'm talking about how many people, how out of how many people, just to make it a little bit easier for people. I'm practicing what I'm suggesting that we should all be striving towards. And additionally, there is that thing that we call the social gradient. So many of you will be familiar with, the core 20+5 approach. And there are no brownie points for saying that when you think about health literacy gaps, it's the core 20 plus communities actually that are the most affected by this. Now, that's the statistics in terms of who is affected, but why does it matter? It matters in terms of people's ability to access. It matters in terms of your experience. So if I'm sitting down in Cresswell, where I'm a GP, and there is a language barrier between me and the patient, neither of us is enjoying that clinical encounter. I am feeling paralyzed by the language barrier or the literacy barrier. They are feeling disempowered as well. So there is an issue in terms of the poorer access, the poorer experience, both for the patient or the service user and those of us that are trying to help them. And that then starts to translate into more serious things like premature mortality. So it's not just I can't access the service. It's not just I'm not having a great experience from the service. It can actually be people dying earlier than they should have because of those divides. And quite frankly, that train story that I shared at the beginning, if not for those people around who could tell me what was going on and I could understand what they were saying, I don't know what the outcome of that particular episode would have been. That is how stark it can get in terms of actually the potential outcomes for people if we have a persistent health literacy divide. On the next slide, thanks. I just want to talk here really that there is a real hard-nosed business case for tackling health literacy issues. And I'm not going to try and go through this slide in detail, but just to say, I'm going to draw your eyes to the last one. What the Health Foundation has shown us that actually, when you think about people's ability to better manage their health because they understand better, that leads to 18% fewer GP visits and 38% fewer A&E visits. This matters because suddenly we realize that this is not just a moral thing of helping people. It's not just an ethical effort. This translates into service utilization pressure. It means that it doesn't matter how much we tweak our clinical pathways of care. If we don't pay attention to this health literacy gap, we are not going to resolve the pressure on the NHS that we all talk about. And this is what I mean by there is a person cost, there is a community cost, and there is that very real business case cost, both in terms of the NHS and service utilization, but also in terms of the macroeconomics of it. The next slide, thanks colleagues for driving this, is the patient safety element. This is where the rubber absolutely hits the road. Many of us will be safeguarding leads. Many of us will have responsibility for patient safety in our organizations. And if you look at the purple part of this slide, you'll see where we're saying communication barriers play a direct role in causing many of the patient safety incidents that we end up grappling with. So think about low health literacy levels is one of the things we've talked about there. People who have different levels of cognitive impairment, people whose first language might not necessarily be English. And you know, I often remember a story, and I commend the Health Safety Investigation Branch report from 2 years ago to really bring this slide to life. And they told the story of the 5-year-old child from the Roma community whose MRI scan appointments kept being sent in English. And of course, the parents didn't understand. And so they, trying to be very diligent parents, kept feeding this child. But of course, she was supposed to have been fasting for the scans. So it got cancelled quite a few times. Cut a very long and dire story short. By the time we got to it, her cancer had spread. She didn't make it. And, you know, so when we talk about language barriers, it's not about race, it's not about ethnicity. This child was from a Roma background. And the fact that, you know, English was not the first language of her parents and her community ended up costing in such an unimaginable way for that family and the community that she came from. And so I just really wanted to share this slide to say, when we talk about health literacy, we need to think about the patient safety element of this and how it translates in very real dire consequences for people. On the next slide, thanks. This one here is around the intersection between health literacy broadly, but also community language translation. And I've already just shared with you that incredibly desperate and sad story from the HSIB investigation into what happened in the case of this 5-year-old child. On my next slide, thank you. It's about, okay, that is the problem. And we've all agreed that when it comes to health inequalities, the last thing anybody needs is an eternal admiration of the problem. So let's just focus now on what can we do. So on my next series of slides, let's very quickly. So we published a couple of years ago the digital inclusion framework. And what we were trying to do there is to say nobody is saying that we should not deliver digital services. All we're saying is look in the rear view mirror and be clear who is not coming on the journey with us. And we've identified the particular people and communities. We've said people who are experiencing homelessness. We've said people with drug and alcohol dependence. We've said people from our Gypsy, Roma, traveler communities, people from some of our ethnic minority communities and other hyper-marginalized groups. They're the ones that we're talking about. And we're saying that there are things we can do, particularly as we pivot into this way of working where if we're not careful, those who are already hyper marginalized will get even more left behind. So do please have a look at this inclusion health framework. The next slide is another framework that we published, which is the digital inclusion framework. So I know that a lot of the care that I provide for my patient, we now do on a digital footprint, and we made that pivot during the pandemic, quite rightly so. But I'm mindful, though, that there are people who may not necessarily be able to come with us quite as quickly, and that is why we worked across the country with loads of stakeholders to develop and publish this digital inclusion framework. But I am a big believer in publishing something doesn't mean to say that anything will change. And so what we've done is we've partnered with libraries across the country, with our colleagues from the Transformation Directorate. Thankfully, there are still lots of libraries up and down the place. And the partnership with libraries is to say, can you please be that sanctuary of support for people who are being digitally excluded, seeing as you are open? Can you please help to just bridge this digital divide using this framework that we've published and making that framework come alive in terms of access to devices and data, the usability of the technologies, giving people the skills to be able to use these technologies, understanding that there is a big issue in terms of belief and trust in some of these technologies, and all of us having the leadership and the courage of our conviction to partner with others, especially voluntary sector partners, to actually bridge this digital divide. So the next slide, thanks. Still talking about the potential solutions. As I said in my opening remarks, this is not just about the people who are struggling with health literacy. It's about us as healthcare staff. Us understanding that when we are writing communication, that we do so in such a way that it is actually accessible to as many people as we can, routinely offering help to people. So when I'm talking to patients at the surgery, actually bothering to check whether what I think I'm communicating is what people are hearing and what people are understanding. And if it's not, to actually just slow down and find a different way of helping people to understand that. And it might be, I'm very fortunate that I work in a place where we do have language line. It might mean that, unfortunately, I will run late because I need language line to help this person understand what I'm talking about and for me to understand what the person is saying so that I'm not inadvertently making access difficult for them, or worst case scenario, creating a patient safety incident potentially for them, and using different techniques, just being professionally curious, having professional curiosity. What does this person need to understand? How do I need to change and adapt the way I'm practicing to enable this person or this group of patients to understand? So it's about us as much as it is about the people and the communities that we're trying to serve. And on the next slide, thanks. This one is to just say, I'm really pleased to share with you that the CQC, working with National Voices, working with the Point of Care Foundation, with input from my team, have published this framework for engaging with people and communities. in order to address health inequalities. And I really draw it to your attention. It's incredibly powerful, useful, actionable. It's not one of those things that you look at, sits on the shelf, gathering a whole load of dust, not really helping anybody. And it really focuses on those core 20+5 population groups that we talk about. So please have a look. Please ask whether people have seen it. If they've not, help us to share it abroad. But most importantly, please let's use it to make access equitable, to make people's experience great, and to give them the optimal outcomes that we're trying to achieve. And I'm starting to round up on the next slide. Thank you, because I think, you know, the richness of this conversation is what comes after this. I'm just trying to very quickly set the scene in terms of why it matters, what we can do, and what we're doing. Finally, is to just say that we've been working, and I was looking at this again late last night, at the level of engagement that we've done to develop this community language translation and interpretation improvement framework, which we are desperately trying to get published, certainly by the end of this financial year. We've got this week, literally, to try and get this over the line. And the reason why we've worked so extensively in developing it is we were determined that this needs to be real in terms of the voices of the people at the margins who get left at the peripheries. So we've worked with our South Central CSU colleagues, with national voices, with academia, with groups of GP practices, with some of our largest NHS trusts. We've worked with NHS providers who represent most of the NHS providers across the country to say, do we really understand the problem that we're trying to solve? And what is it that people said will help? And so I'm hoping that when we publish this framework, it won't be the be all and end all of everything, but my hope is that it will give us a coherent, coordinated response to what is currently a very fragmented landscape in terms of how we really come alongside and help people to bridge the multiple divides, whether that's health literacy or digital literacy, or indeed community language translation and interpretation. So that is where next, that's where we've been. This is where we're going next. And I hope over the next hour and a half that you're going to be in this virtual room together, that we get to a position where we share the pain with our patients and with our service users, that it's not just about them improving their health literacy, but it absolutely is about us doing our best endeavors to be more accessible to them. So I think I'll stop here and I'll hand back to Ryan, because there's a really important and rich conversation to follow from here. Thank you.
Thanks very much, Bola. That's great, and lots of claps and hearts there as well, so very appreciated. If we could just move on to the next slide. I introduced myself at the beginning, that my name is Ryan Swires, consultant in public health. I work a day a week for the Integrated Care Board here in the North East North Cumbria, and my colleagues that you can hopefully see on the screen there, Emma, who's the strategic manager of our health literacy team in the region, Lorna, who's our health literacy specialist, and Leanne and Tracy, who are our health literacy trainers, along with a couple of other members of staff not involved today, Alex and Kia. We make up the regional team, so very fortunate in this part of the world that we have a health literacy team trying to make progress, I guess, on some of the things that Bola has touched on there. So you'll hear from all of us throughout the afternoon, and I think I'll hand straight over to Leanne, who's going to just find out a little bit about what you know already.
Thank you, Ryan. Hello, everybody. As Ryan just said, my name's Leanne. I'm one of the trainers on the regional team. I don't really know how to follow Bola, to be honest, because I think she was very thorough in her explanation. But, you know, I just want to pick up on one thing that she did say, and that she was really, you know, driving the message on why health literacy matters. And, you know, and you're in for a real treat this afternoon, because what we are going to do is we are going to really talk about the message that, you know, us as a team get across to all of the staff across the North East and North Cumbria, and how they can use that to make improvements. And then we've got some real examples of the work that's been done at one of the trusts where it was all started, and then how we've kind of rolled that out across the region. So yeah, listen up, because you're in for a good hour and a half. So the first question that I really want to ask you all is to rate your health literacy knowledge. So one thing that Tracy and I have really, had our eyes open to over this past sort of just over a year is that there is a real varied knowledge on what health literacy is, and and what people can do about it. So some people have a little bit of an idea. Some people genuinely across the hospitals will say, I've never heard of that. I need to Google that. I don't know what it is. And I suppose that's why we're here, and that's why we are raising the awareness. So yeah, if you can have a think about where you're at right now in terms of what your knowledge is on health literacy, where would you put yourself on a scale from 1 being not very knowledgeable, which is fine, by the way, there's no right or wrong answer here, and 10 being very knowledgeable, and that you could be on the panel with us this afternoon. Whereabouts would you put yourself? Just have a little think and give yourself a score. Don't worry, this won't give any names and who you are and where you're from and what your knowledge is. This is just for us to get an idea of where people are at the moment. And we are expecting it to be quite varied. And I'm just seeing some of the scores on the doors come in. And yeah, it is quite varied. A lot of people middle of the road, at around about 5 or 6, some higher than that, some lower than that, which is to be expected. And we are going to hopefully at the end of this you will either go away with confirmation that what you knew is right and you're on the right track, or that we are giving you some real awareness and some hints and tips on what you can start to do, boots on the ground wherever you are, and what you can do in your own roles. So we like to, I know it's mics off, cameras off, but we do have some polls, some questions for you, because we are quite a chatty little bunch in the Northeast. We like to hear from you all, and we like to know your opinions. And there are 628 of you on the call, and we still want to hear from you all. So yeah, there will be some polls and some little word clouds for you through the session. So what is health literacy then? I think Bola did a good job as an introduction to what it is and why it's important, and what we can be doing or what we should be doing. But really trying to think about, what health literacy is in your own roles, and how it applies to you and the people that you are seeing day in, day out. I suppose that's what we're here to tell you about, So when you think about health literacy and what it is, I just want, before we get into it, I'm going to put some information on the screen now. And I just want you to read it. And then when the little word cloud comes up, I just want you to put one word in that description and how it makes you feel when you look at this and when you read it. Can you read it? Can you tell me what it says? Have a look at that. Oh, here we go. They all popped up at once then. I don't know about anybody else, but we've got confused, bamboozled, garbled, nonsense, challenging, gives me a headache, frustrated, overwhelmed, annoyed. Welsh, I wondered when that would pop up because it comes up every single time. Anxious, clueless, stupid, panic, dizzy, reading another language. Yeah, these are all of the things that disempowered. I am going to come back to that in just a moment. Really need to concentrate, gives me a headache. I think I've said that already, but I think it might have popped up again. So you can start to see why this is going to be a problem. So then I'm just going to close that off on my side, because before we move on, I want to pick up on a few things on this. So I have put this on the screen and I have basically said to you all, right, there's your information, read it, tell me what it says. And, someone has very importantly said in that, that makes me feel disempowered. And I suppose, and I'm not putting any words in anybody's mouths because I can't have that conversation with anyone, but it's almost that, you're not able to use that information. I've given you something and I've said, go on, read it and, tell me what it says. And you're not able to do that because it's irritating, it's confusing, you think it's a different language. And when we are given written information to a lot of people across our region, across the country, because I know we're all over the place. These are the feelings that a lot of people will genuinely have when they are faced with any written information, whether that is a letter, it's a leaflet, it could be a text message, or an email, a poster, all of these things. I don't know if anybody is aware of the reading age. Spoiler alert, you are going to be asked about it when Ryan comes back on. So it is, the average across the UK is 9 to 11 years old. That does vary, and it will vary from place to place. It will be higher in some places, lower in others, but the average is 9 to 11 years old. And a lot of the information that we put out is currently at a reading age a lot higher than that. So, you know, we are having the opposite effect for a lot of people. People are confused, people are irritated, and a lot of the time that information will just go in the bin and never to be revisited. The problem with that is that important instructions will be missed. You know, people could be jumping to the wrong conclusion and think that something isn't that serious when it is, or someone could think something's really serious and actually it's not. You know, a good example we use of that is the word positive. You know, positive's a good thing normally outside of the medical world, but if you test positive for something, that's not necessarily a good thing. So yeah, it just starts to draw your attention to the written word on paper. And I can see a lot of comments coming into the Q&A as well, so we are going to try and keep on top of these, but if we can't, we'll address them all at the end. So then, what is health literacy? So health literacy is being able to access, understand, check and use information to make choices about health. So this is the World Health Organization definition. The access side of things, you know, Bola had said at the start, it's usually those in the greatest need that have the worst or poorest access to healthcare. And you know, and information is a barrier to that as well. So we could talk about that all day. We don't have time, unfortunately, but yeah, it's having the access in the first place, then being able to understand that information, check it and use it yourself to make true informed choices about health. And I can already see lots of consent comments coming into the Q&A, so it's good that you're already on that thought process. The World Health Organization did update their definition to basically put a bit more responsibility on organizations. It's our information that we are given to people, whether it is through the spoken word or whether it is written down. So it's up to us to make sure that we are really giving it in a way that people can understand and use. Otherwise, we are causing that problem and we're making it worse. Now, in order to be health literate, there are some individual skills that, you know, someone would need. So this is Professor Donald Nutbeam's model on the skills for an individual. And as you can see on the screen there are 3 different levels. So we've got functional, interactive and critical. On a functional day-to-day basis, someone would have very basic reading, writing and numeracy skills to understand simple health information and, you know, simply get around a system. The example that we give to that is usually a lot of, you know, think about your working environment and what have you got on display. So posters, very simple wording on posters, signs, prescriptions. Someone would be able to look at it, you know, and say and recognize that something says, you know, 2 tablets 4 times a day. So they can function to that degree, but not really much more than that. And across, especially obviously, we're going to go into the work across our region soon, and across our region, that is where a lot of the adults are at the moment, functional to interactive. Now, interactive is you know, there's more skill to that. So people would be able to pick out information that they need, discuss it and apply it to different situations. So someone would be able to have a better conversation with a healthcare professional and really start to articulate any symptoms that they might have, any feelings where they are on a pain scale, things like that. But also a very simple example would literally be, you know, you could be a vegetarian looking at a chicken curry recipe and you know to swap the ingredients out, or, you know, you could have a health condition that requires a strict diet. So you know, you're going off and you're able to read labels and pick out things that you need or that you need to stay away from. And you can really start to use that information for yourself and your own health. But operating day to day on a critical level, is what someone would really need to be fully health literate. So that would be able to also analyze any information that you're given and work out if it's reliable and if it applies to you. So the example that we give here, I mean, heaven forbid anybody has ever given, a diagnosis of any description. You get given information at the time, but you also want to go off and do your own research and, as we do, and that's fine. But on a critical level, you'd be able to really look at some information and decide whether or not it's reliable. If something was written back in 1998, you might be questioning whether that is the most up-to-date, reliable information. Is there something else that has been done more recently? Who did that study? What are their credentials? And you can really start to drill down and decide if something is reliable. So those are the skills when it comes to being health literate. And a lot of people ask us a lot, well, what does that reading age look like? What does it mean for someone to, be reading at a reading age of 5 to 7 or 9 to 11? So just to give you an idea of what that looks like here, we've got this little table. So just to draw your attention to the 9 to 11 years old, which is what a lot of work has been done in our trusts and across our region. This is what we kind of rewrite to, because this is what the ability is there. So on a 9 to 11 years old, it would be able to understand more complicated posters, but with still simply worded leaflets. They'd understand short formal letters. They can have a call with 111, as I said before, and start to articulate things. And they'd be able to understand what they've been prescribed. A lot of the time we hear, when Tracy and I are doing training across the region, we'll hear questions, do you know why you're here? And a lot of the time people will say, no, I don't know what this appointment is for, or no, I don't know what I've been prescribed this medication for. So yeah, it's just to be mindful of how information is being delivered. So if we look at that definition in the middle of, being able to access, understand, check and use information, with the outcome being to make informed decisions about your health, there are obviously things that are going to feed into that. So over on one side, we've got personal characteristics, and we hear a lot of the time people saying, well, let's get out in the community, let's upskill communities, give people better literacy and numeracy skills so that they can understand the information that is going out. And nobody's disputing the importance of that work. That does go on. But as an organisation, we've recognised that takes time, it is expensive, and it's not necessarily something that we have a lot of control over when it comes to someone's individual characteristics. Whereas when you look at it from, well, what can we change large scale? Let's look at the information, that you have more control over that outcome. We also look at the society and environment. And when we talk about that, it's thinking, like I said before, your working environment, where you're at. Do your signs match your letters? And I know that sounds like such a basic thing, but there we hear time and time again that someone knows they're going for an appointment for their skin, but the signs say dermatology, so they'll turn around, or x-rays, probably the most common one. The paper will say you're going for an x-ray, but the signs say radiography, and people don't put 2 and 2 together, but should they have to, if the letter says this is where you're going, then surely the signs should reflect that. Oh, I got a thumbs up there. I don't know who that was, but thanks very much. But yeah, so it's really making sure that the information that is on display is just as useful as the information that you are speaking or handing to somebody. Then we've got the social resources. And I know I wrote this down actually, because Bola said it and I thought, oh, I quite like that. And it's looking at the resources that are available, in communities, and this is part to do with the access side of things. If somebody, and we do have a massive amount of deprivation across our region, I'm sure wherever you are in your own areas, you will be able to see the spread of that, across wherever you are. But it's looking at what people have available if they don't have it themselves. So if somebody doesn't have a mobile phone with credit on or broadband at home, Do they have a local library? And I've wrote down sanctuary of support. I quite liked that. But where is the support, you know? So do they have a local library that they can get to? Is there a good bus route that gets them there? Or do they have to pay for a taxi? Because then that's a separate conversation on affordability, you know, what's the priority for the individual? So there's all of these things that come into somebody being able to access, understand, check and use information. Now, there was a study done by Professor Jill Rowlands. She's an academic at Newcastle University and she's a GP up here as well. And she did a study into the groups of people that are more likely to be affected by low health literacy. And this was the outcome of the study at the time. So just to pick out a few, because I'm very conscious of time, you know, we've got unemployment, low job grade and low income. We've got lower qualifications. So it's, you know, it's no surprise that if you are behind where you're expected by the time you leave school, a lot of the time that will transfer into your adult life. Being born outside of the UK and English not being your first language, you know, we touch on that a lot in terms of that's going to put a natural barrier there. And age, you know, as we get older, our memories aren't as great. Maybe digital access isn't as great. So yeah, all of these groups of people are at a higher risk of having low health literacy. Doesn't necessarily mean it's a definite. So if anybody is on the call and they're over 45 years old, this isn't putting you in this bracket. It's just being mindful of, you know, these are the groups of people that are at a higher risk. This was done back in 2015. It hasn't been updated because the survey hasn't been updated, but it was on the Skills for Life survey and the census. But actually, we would probably see more, you know, Bola touched on a few extra groups of people that we'd probably see on here. We'd see more rather than less. So, you know, you can see that this is a huge amount of people that are going to be affected by low health literacy. Now, nationally, it's currently 58% of adults that would find it hard to understand health information that contains words and numbers. Now, for anybody that likes to, you know, follow things up, you will find this data from the Geodata website. I'm conscious of how I say that because of my accent. But yeah, the Geodata website, if you go onto there, you will be able to, it will tell you national average, but you can also put in your own locality and you can also put in, you can choose literacy or literacy and numeracy. We went on both because health information tends to contain both. And it will then show you where your locality is in line with national average. So when we get into a little bit later, we'll be able to show you the work that's been done around our statistics. But nationally, it's still 58%. And that is still more than every other adult that we speak to. So, you know, we have to be mindful that that's a lot of our adult population. However, everybody can be affected by low health literacy at some point in your lives. You know, you could be the most educated, literate person in the world, but still struggle to understand health information. For a number of reasons. First of all, we're not experts in every field, but also, you know, we could suffer a trauma, we could be under real stress or, you know, extreme fatigue or just illness in general. For us, for those people, it tends to be a more short-term thing. The groups of people that we've seen previously, it's usually, you know, long-term to lifelong, and by making the changes that you're going to see coming up, but to help those, we're actually helping everybody. So I hope that you think, I just want a few thumbs up or whatever at this point, that this is something that we need to really get in control of and, you know, get on top of. Oh, there they are, they're all flying up. Thanks very much. So before I hand back over to Ryan, I just want to have you think about, because you're going to start to see all of the work that we've been doing up north and across the northeast and North Cumbria. So we've got a little questionnaire basically for you to think about now, so that you can start to think about the support that you might need to make the changes that you've seen us make. So yeah, if you can scan the QR code, and then as you're listening to the work that we've been doing, it might give you some ideas on what you've got or what you're lacking, and yeah, what support you might need. But I am going to hopefully hand over to Ryan, who's going to add to the importance of what we're doing. So yeah, thank you very much, everyone.
Thanks very much, Dan. That was great and warmly appreciated. I can see lots of you putting your hands up. I'm going to be rude. I'm going to ignore those hands for the time being. We will come back to people at the end, if time allows. If you have got questions, do pop them in the question and answer section. We'll try and get back to you as we're going. People are monitoring that chat, and we will. If you've got burning questions, we will try and pick them up at the end. But just so that we can get through all of the content, I'm just going to plough on if that's okay. So Bola touched on a little bit of this, but before we get into some of the practical examples of work that we've done, I want to just stress why this is important. We're all busy. Most of us here will work in the NHS, and we'll have a number of pressures, targets, obligations that we have to meet. This work risks being nice to do, a nice extra thing to do, a bonus bit of work if you've got time. I think what we're going to try and convince you is that it can't be that. It's much too important for that. And it's really important work because of the difference it makes to patients and the public. If you remember nothing else, just remember this, that relationship between adults who've got low health literacy and their family. They are the people who suffer the worst health outcomes in society. There's an awful lot of overlap with some of the risk factors, but those core 20 plus groups that Bola talked about and people will be familiar with, health literacy has a significant overlap with those groups. And this list is quite depressing, but it could be much longer, I'm sorry to say. So people with low health literacy are more likely to die younger, to have more long-term conditions. So shorter life and more of their shorter life in poor health. They're also more likely to miss appointments and to struggle to take their medication properly. All of that leads to these people who have low health literacy feeling stressed, worried and angry and really struggling to look after their own health. So when we add all of that together, it's a real problem, and a real problem that affects patients, the public and our services. Now, this is quite a busy graph, but I think it's an important one. So if you just bear with me, across the x-axis on the bottom, you've got people, adults in the UK, from very low health literacy to very high health literacy. And then on the y-axis, up and down, you've got long-term conditions. So that's what the colours represent. So green means no long-term conditions, amber is one long-term condition, and red is multiple long-term conditions. So what this graph shows us is that those adults who've got the greatest health need, the greatest burden, they've got the most long-term conditions, they need our help the most. They've got the lowest health literacy. So these are people who will receive the most healthcare appointments, the most letters, the most leaflets, the most communication about their many healthcare conditions. And we know in advance that they've got the least capacity to benefit from it in the way we produce it, but we do it anyway. So just hold on to that we're here to talk about health inequalities. If we don't do some of this work differently, if we don't improve our part of the health literacy picture, we are potentially creating and exacerbating health inequalities rather than tackling them. But it affects staff too, and it affects staff in a number of ways. So it affects staff because their workload increases at a time when actually we need to be working with constrained budgets, we need to be more efficient, but actually poor health literacy on our part as organisations creates some waste, it creates more issues in the system. It also can be extremely damaging for staff morale, working with patients who are just not understanding, just not getting it, just not able to receive the benefit that they need. That affects job satisfaction, and it also affects the quality and the safety of care that we provide. So it affects staff indirectly through the relationship on patients, but it also affects them directly. So just think about your workforce. A large proportion of them will be recruited from your local population. So if low health literacy is a health issue in your local population, that's your staff too. So that's your staff policies that you write for them. Are they written for everybody? That's the communications that go out to all of your workforce. Is that accessible, easy to understand for everybody? So it affects staff as well as patients in a number of ways. And overall, Bola touched on some of this. if we fail to act on health literacy, it's bad news for us as organisations. It's costly, really costly, and it is a safety issue. Lots of evidence around medication errors, for example. Services are often used incorrectly, and sometimes patients can be blamed for that. But actually, we need to bear some of the brunt of that if we're communicating in a way that we know will make it hard for some people to understand. If we don't do that, it does add pressure on the system. And it, as I've touched on, it directly contributes to health inequalities. So this stuff really matters. I think because of the name of this webinar, everybody will be familiar with this, but I'm going to say it anyway. Health inequalities is what we're all here for. It's what we're all here to tackle. Just a reminder of what we mean when we say health inequalities. So the Dahlgren and Whitehead rainbow model here that you can see has all of the determinants, the things that affect health. And all of them contribute to somebody's health outcomes, but those health outcomes differ. And they differ between groups. And when that difference is unfair, systematic, and avoidable, that's a health inequality. And the next slide just shows the same image, but thinks about health literacy specifically. So just think about all of those different determinants of health. Health literacy is in all of them. So yes, we might only have some control over the healthcare services bit, but just think about health literacy in relation to housing, in relation to employment, education, and so on. It cuts right across everything. So we're all here because these things matter to us, but also we've got lots of organisational drivers for us. So lots of us will be working towards the core 20 objectives and other targets in our organisations. The World Health Organization directly recognises health literacy as a determinant of health. So not a byproduct, but a direct determinant of health. And it also recognises health literacy as having the ability to tackle and reduce health inequalities. Health literacy is also seen as something which can empower citizens. So when some of you put your comments on the word cloud earlier, we could see that actually you felt completely disempowered because you weren't really sure what was going on, what was being said. Actually, if we get this right, it can have the opposite effect. And health literacy can, as I've said, have an important contribution to health outcomes, full stop. So I have a few questions for you to see if you were paying attention to what Leanne was saying. So you'll be back on your mouse again, I think, here. So question number 1, do you know the average reading age of adults in the UK? You can pop your answers on now. Just wait for a few more. We've got 600 plus people in, so let a few more respond, but this is looking good. You'll have been paying attention. And again, there's some discussion about this statistic, but I think there's less discussion about the fact that the reading age of the population is low, and it's poorly aligned with the information that we generally provide for people. So what did people say? The answer was 9 to 11. So I think most of you were on the right track. Let's see how you get on with this one. How many people cannot measure height and weight on a chart? So again, we're in the UK here, so think about our population and how many will struggle to measure height and weight on a chart. Okay. 6.5 million. This is not a small issue. This is not a side issue. This is a big ticket item. This is huge numbers of people that we're talking about. Okay, next up, what percentage of, let's just move for me. What percentage of people say they don't fully understand the leaflet in their medication? So everybody's probably had some medication or seen some at least, and a little leaflet usually comes inside it. I'm sure you all read it cover to cover. What percentage of people don't fully understand that information? I see most of you have responded, and most of you are on the right track. So about half of you, I guess that's 68%. That's quite staggering when you think about that. Almost 7 in 10 people. It's quite staggering. What percentage of people with very low health literacy have one or more long-term health conditions? So this will see if you're paying attention to the graph that was up earlier. And they're all pretty close. So you're this is maybe a bit trickier than some of the other ones. Okay, so yes, 73%. So 73% of people, low health literacy, have a long-term condition. So it's important that the information that we provide for them in any format is easy to understand. And Bola did give some data on this, so Bola gave a bit of an insight into this, but there has been some more recent work done. So we've got some slightly updated costs. So roughly, how much did low health literacy cost the NHS 4 years ago in 2021? Bit of a mixed spread here, people, different views. But the true answer is a very big number, 5.3 to 8.8 billion. So as I said at the top, this is not a nice to do. This is not some side issue. This is a big ticket item for all sorts of reasons, not least finance. A whole range of emojis popping up there. Okay. Hopefully this is a straightforward one. So now that you've heard all of that, do you think that this needs to change? Are you happy to just ignore this, or do you think something needs to be different? And I'm hoping there's a lot of thumbs up. I haven't seen any thumbs down. Hopefully, if people think this is something that we need to do something about, I just want to come back to this point. So Bola touched on this, and we use this image or one like it a lot. If you think of health literacy as a two-sided coin, we can think about the level of health literacy that individuals and communities have. And yes, we would like that to be higher. That would be great. And there's lots of great work going on around that, which we'd be very supportive of. But if I think about my role, and if you think about your individual roles and your organizations, where can you have the most impact, the big systematic change? We think it's on our role, organizations and systems. So us getting our bit right rather than just expecting other people to do something different and meet us where we are. So in an ideal world, we'd see these arrows meet in the middle, but the focus of our work is very much on bringing down the health literacy levels of our organizations and systems by default, not as a special thing, but just by default. And this is a really good example. Everybody here wants to tackle health inequalities. That's a really tough thing to do, really difficult. And having concrete, tangible examples of things that you can do that can make our services fairer and more equitable, they're like gold dust. And I think what we're going to talk to you today a little bit about is health literacy can be one of those. It can be something which can directly, is within all of our controls. We can all do something about it, and it can directly have a positive impact on health inequalities. So I'll leave that with you and hand over to Lorna, who's going to talk a little bit about some of the work that we've done locally in our trust.
Thanks, Ryan. Can you hear me okay? I'm just going to, yes, I've seen a thumbs up. Thank you very much. So hi, everyone. Thank you for taking the time to listen to us today. My name's Lorna Dawson. I've got two hats. I do health literacy at South Tyneside and Sunderland NHS Foundation Trust. So at trust level, I also do it a bit at kind of like local area level, and also I'm part of the regional team as well. But today I've got my trust hat on, and I'm going to tell you about kind of what health literacy work we've been doing at South Tyneside and Sunderland NHS Foundation Trust. So we are an acute hospital trust in the northeast of England. We provide a range of healthcare services. We look after people at home, people in the community, and people in the hospital. We've got 2 big hospital sites, but we've also got lots of community sites. So we work in local health centres, schools, GP practices. We provide lots of different types of care, so kind of like standard hospital care, mental health support, but we also run specialist services. For example, we've got kind of an eye infirmary. So that's kind of the context that we are doing this work in, like a big, busy acute hospital, but with community sites as well. That's our hospital, but who are we? What are our local people like? Who are we kind of aiming to help? So you might be able to tell from my accent, I'm not from the Northeast. I've been around for almost 3 years now. And one of the first things that I learned when I moved up here was that people are really kind, they're really friendly, they'll always chat to you, they'll always offer you a cup of tea, massive football supporters. But sadly, our local people, their health is like overall worse than the UK average. So our local people tend to die younger. They have fewer years of good health. 1 in 3 have a long-term health condition, and around half live in an area of high deprivation, so in the 20% most deprived areas in the country. And if that wasn't bad enough, around 65% of people struggle to understand health information that contains words and numbers. So that's things like your GP appointment letters, but it's also things like information on prepackaged food. So not only is the health worse in South Tyneside and Sunderland, health literacy levels are also worse as well. So this is an area where we need this work a lot. And so that's why we were kind of doing the work in this area. So the first step in our health literacy journey actually happened before I got here. So Ryan worked with his colleague Fiona, and they were kind of flying the health literacy flag for about 2 years before I managed to arrive. And they actually started doing it by stealth. So there was a big engagement activity in the trust looking at the vision and values because the trust wanted to rewrite them. And some of the feedback on those vision and values were that they were too long and wordy, needed to be kind of simpler. It felt very corporate and not very human. And it needed to inspire people, but kind of use the language that everyone used. So our comms director was really on board with like the concept of health literacy and doing things a bit differently. So Ryan and Fiona supported them in rewriting the trust vision and values. So originally they were a reading grade of about 18 to 21 years, and we wrote them at a reading age of 7 to 8. And I think this has been really helpful to kind of have just a really big visible commitment to health literacy right from the start, in that our vision and values are written in a way that's really easy for people to understand. The next step was getting senior leadership buy-in. So this has made my job so much easier. So we've got a video of Ken, our CEO, who we're not going to play, but it basically says health literacy is important. And kind of whenever I go to people, I can say kind of like, well, Ken thinks this is important. So actually kind of and he asks kind of other senior managers, have you thought about health literacy for this? So we don't have to fire our flag, it's people kind of have to do it, and being told by really senior people. So that's been really helpful. I guess a tip, what really got them engaged was kind of Ryan saying people's reading age is this. but we're giving them information at a much higher level, and we can do something about it. So that kind of gave us permission to have a small health literacy team to do a project. So this is the project that we did. So in a nutshell, we rewrote over 800 health leaflets at a reading age of 9 to 11. It was big. 800 plus is a lot of leaflets. It was ambitious, but we decided we wanted to do something. We wanted to do one thing well, with big numbers, rather than doing lots of little things, which made less impact. So with this, we could really see the big impact of a big change. Thank you for the claps and hearts. And I think Emily is on the call today, so she's done a lot of the rewriting. 800 leaflets is a lot. The way that we work is really quite systematic as well. So before we do anything, we try and work out, is it actually a problem? We thought it was, but we needed to check before kind of changing 800 leaflets. And this is what our leaflets looked like before we did anything to them. And to be honest, this probably doesn't look that bad. It probably looked fairly kind of familiar to everybody. What we did first was an audit of the reading age of the leaflets, because we estimated that the reading age of our local population was about 9 to 11. But when we did an audit of our Trust Health Information leaflets, we found that 93% of them were written higher than that. So that's over 90% of our leaflets aren't appropriate for the reading age of our local population. So we thought, yeah, there is a problem. We need to change that. But we felt that numbers aren't quite enough. We wanted to hear from our local people to check whether they felt that the leaflets weren't kind of appropriate before, again, making such a big change. So we went out to the community, and what they said when we gave them the leaflets was things like they were daunting. It sends you into a panic. And that big block of text in the middle, that would stop me from coming back. And you wouldn't think that words on a page have an effect on something like attendance rates or DNA rates. But I think these quotes, which are really powerful for me, show that they do. But also it's nice to know that actually it's something as simple as changing words on a page can have a big impact. So we'd shown them the leaflets as they were before, and we then showed them kind of examples of how we wanted to write them. So we showed people leaflets rewritten at a reading age of 9 to 11. So that was kind of just testing kind of whether the way that we wanted to write them and do things was appropriate. So we did a massive amount of community engagement. So we spoke to about almost 400 residents. We spoke to like 50% of them were from our most deprived areas. So we really wanted to kind of do this intervention for people who needed it most. And we wanted, to hear from the people who needed it most. And I think we really managed to do that, and which we're really proud of. And what people said was that they liked it. So 94% said there weren't any medical words that didn't make sense. So basically kind of it's understandable. We also asked if people felt patronised or talked down to. Staff were really worried that, people would feel offended, or like we were talking to them like they were a child if we wrote at a reading age of 9 to 11. But actually 97% of people said that it doesn't make them feel that way. And then of those, that 3% that said they did feel talked down to, 93% said they would still follow the advice, which was good. And people said things like the way we wrote was straight to the point, no waffle, layman's terms, boring, which I'll take, easy to follow. So we felt like this was permission to go ahead and make large scale change. So there are lots of changes that we make to leaflets. This is just a snapshot. We talk about reading age, but actually we do a lot more than that. So things like splitting up sentences and paragraphs, changing jargon. You'd be surprised at what a difference it makes adding headings and bullet points to documents, but people say leaflets are much easier to navigate if you add those in. I'll give you a bit of an example as well. So here kind of I've got a before and after. So on the left we've got before, and that is one long sentence. I'm not entirely sure how many words that is. I'm going to guess it's over 20. So we've kind of broken it down. You've got bullet points there. We've got that extra kind of heading. So people will probably look out for symptoms or signs. So that's really easy to identify with that kind of heading, signs you may have CFS. There are words like fatigue, which is not due to ongoing exertion. So feeling tired even though you've not been doing physical work or exercise. Not substantially relieved by rest. Like you rest, but it doesn't help. So those are the kind of differences. So it's saying exactly the same thing. It's just saying it in a much more everyday way. So we've done a massive amount of work, but one of the important things is kind of, does it make a difference? We partnered with the University of Sunderland, and they did an independent evaluation of our work. What they did was they recruited patients and staff from 2 departments, and they showed them leaflets before we changed them and after we changed them. And these are the kind of things that they said. So people reported feeling really overwhelmed with the information as it was given before. They felt like it was kind of all too much. Information was like too detailed. There was too much kind of complex medical jargon. And this was a barrier to understanding the information, actually kind of applying it or doing what it said. But kind of what people said when we gave them the new leaflets was that it didn't make them feel patronized. It actually made them feel empowered and more in control of their own health. Before, people genuinely said that they would just throw the information away. Like they knew that they were going to put it in the bin when they went home. But with kind of the new information, people said that they were much easier to understand. They felt like they could take them home and look at them in like at their own pace, in like their own environment. And like they commented on the tone, how it was like more approachable, which meant that people felt more comfortable asking questions, so taking a more active role in their care. I think we had the quote earlier where people said they felt daunted or it sends you into a panic. People also said in the evaluation they felt too scared to ask questions because they didn't want to feel or they didn't want to look stupid. But what people said about the new leaflets was that they were much friendlier, and that actually made the service seem friendlier. They said things like it made them feel like understood and cared for and more supported, which is amazing for a leaflet. Lots of staff said that they had appointments where they were essentially translating information for people that was too complicated, or they'd find themselves explaining the same thing at the appointment afterwards because it hadn't been understood, so they'd had to repeat themselves. So that kind of adds a burden to staff and their time. But then patients said that with the new leaflets, they felt that they could take the instructions away and follow them. And they felt like they wouldn't need to have to come back to ask for help because they understood what they said. So that's definitely a win for empowerment and also kind of reducing that pressure on services as well. And an important thing is that there's a potential for it to make care safer. And this is just a story about a diabetic patient who was told they had to eat more fruit and veg. and they actually ate 49 bananas in a week. And they thought, I'm being healthy, like I'm eating more fruit. But actually what was happening was they were getting kind of potassium poisoning. And so they felt like, yeah, if the information had been explained in a way that was a lot simpler, yeah, that risk wouldn't have been there. And I guess this is just to add, like, we think this is really important. It's nice to have the evaluation to show it works, but we've also been recognised in a lot of different places with a lot of different awards for the work that we've been doing around improving health inequalities. So it has been really good, a really important journey. But I always had to, when I started out on this, I always had to think, how do I make it so that this change lasts even if I'm not here, kind of thing. Because health literacy like shouldn't be one team's job, it should be everybody's job. So we really tried to kind of make it sustainable and make it kind of last in practice. So one of the things we've done is now we've got health literacy as part of the leaflet process. So before something gets kind of like signed off by clinical governance, there's like a little step in the process where leaflets have to go to our team. And they have to kind of meet our standards. We've also developed a watermark, which is the little round tick that you might be able to see. And so kind of that means that information has gone through our process. And now kind of people can start to recognize, oh, if it's not got that mark on, why hasn't it? So it's a bit of behavior change as well, kind of making it seem very normal to have this mark on and getting people to kind of demand and ask, oh, why doesn't it? Another thing that we're really proud of is that we've got all our strategies written at a reading age of 9 to 11. So they were refreshed last year. And 6 out of 8 of them say that they'll do health literacy. So, for example, our patient safety and quality strategy says we'll make sure we communicate clearly and explain things in a simple way. So I think that's a big statement from the trust, and that will definitely kind of make sure that health literacy is kind of like a focus of the trust for the years to come. And as I said, health literacy shouldn't just be one team's job, it should be kind of everybody's. So we've made a page with lots of resources on our intranet. So things like guides, video tutorials, we run monthly training, we've got links to tools and stuff, which we'll be linking to later on. And what this has led to is health literacy work. So we started off in the trust, we branched out to place, and we've also been doing regional health literacy work as well. So yeah, it's been a really great journey, and we're hoping it'll carry on. So thank you very much for listening. And I'm going to hand you over to Emma, who will talk to you about the work that we've been doing regionally.
Thanks, Lorna. Hi, everybody. I'm Emma. My name's Emma, and I'm just going to talk to you a bit about the work we've been doing across the North East and North Cumbria. So the work that we've done on that regional scale. So just to give a bit of context, first of all, so the North East and North Cumbria integrated care system covers the biggest geographical area in the country. We look after about 3.1 million people and employ a NHS workforce of 170,000 people across health and care. And we've heard earlier on in the presentation quite a lot of data around how many people would struggle to understand information with words and numbers. So 58%, as Leanne's mentioned, 58% of people in the UK find it hard to understand health information containing words and numbers. It's slightly higher in the North East and North Cumbria, it's 62%, and there is some areas within the region that are higher than that again. So for example, 68% in Middlesbrough. Across our region as well, just to add to the context, we have about a third living in the 20% most deprived areas of the country, and around 25% have 2 or more long-term health conditions, And again, you've heard earlier on in the presentation around the links between people with low health literacy and those long-term health conditions as well. So to do the work across the region, we needed to come up with a plan. So we needed to think about how we took the learning that from the work that Lorna and the team had done at a local level, and how we built on that and the evidence that was already there. And also had to think about how we made it work at a much bigger scale and make it fit for different types of organisations, so not just NHS, local authorities, the voluntary sector, primary care, and also not just the written information, so how we looked at spoken information and also the environment. So we heard from Leanne earlier again around the impact that the signage in the hospitals can have. So we needed to think about all of that and how to plan to help that across a regional scale. So this is the work plan that we developed for the region. So we made the work plan, which is where we started. It includes involving local people, setting up a team, finding out what's already happening so we can build on examples of good practice that's already out there, setting up a network, which you'll hear about later. So we developed a community of practice, and you'll hear more about that towards the end of the webinar. Working on patient pathways, working with estates, so how we influence estates from a health literacy point of view, to help people be able to get around buildings and get to appointments in a better way. Developing training, making a toolkit, getting other organisations to sign up to doing health literacy, developing a set of standards and checking how well we're doing with all of that. So I'm going to talk through a few of those in a lot more detail in the next few slides. So firstly, just to let you know about the team that we set up. So we were lucky to have funding available from the North East and North Cumbria ICS to set up a regional team. So that included Ryan as the health literacy lead, myself as a strategic manager, Lorna, who you've just heard from, as a specialist. We've got a health equity coordinator, Alice, who isn't here today. The health literacy trainers, Leanne and Tracy, and health information assistant editors, and two of those, Kia and Alex. Like I say, a number of us are talking to you today. And just moving on, so like I say, we've got two trainers in the team, and the training has been a huge part of our work over the last year. The focus, there's been a lot of focus on monthly webinars. So we've ran monthly sessions which have included health literacy awareness, how to write simply and speaking simply. But we've also had a number of ad hoc requests for bespoke sessions, which have been great because we've really been able to tailor the training to meet the needs of the team. So for example, a pharmacy team got in touch and they'd had a lot of calls from patients querying letters that they've received about changes to medication. So Leanne and Tracy developed a session on health literacy, and then people within that team took it on themselves to go away and rewrite their letters with the support from our editors, and we'll be looking back at data just to show if that's what impact that has had. We've also developed mastery level trainings for those who really have a focused role with communication as part of their day-to-day job. We've done targeted training as part of pathways, which I'll come on to talk about in a few moments. We've also created our local training videos, and some of you may have heard about the language of health video that's available, and we've been developing a regional version of that, which will be available soon. We've also started, which has been really positive, started to introduce health literacy into the curriculum, and Leanne and Tracy have delivered a few sessions for the University of Sunderland medical students, and one of those was a How to Write Simply session where medical students were needed to create their own patient information leaflet, and their lecturer said that she'd noticed a huge difference in the leaflets that were created this year in comparison to the ones that we created last year. So that was really, really positive to hear. So far we've trained over 1,300, so I think it's around 1,000, well, it's over 1,400 at the moment, so that's really positive. And we've been working on a train the trainer program to really increase capacity to deliver health literacy training across the patch. And this is just a snapshot of what everyone's been saying about our training. So it shows that people are bought into it and really recognise that health literacy is an issue. So some people saying, I found your input and support invaluable. It's completely changed the way I approach patient information. And people acknowledging that it's such an important topic and it needs to be in universities and inductions. And that was phenomenal. So that's like I say, just a snapshot of what people have been saying, which is really great to see. As part of our work, one of the most important parts is to involve local people in what we're doing, just to make sure that we're getting it right. So we do this in a mixture of ways. We speak to community groups regularly to get feedback on what we're doing. So that might include just going out and asking generally what challenges they have when it comes to healthcare information and how they think it can be improved. We also take out current versions of patient information leaflets again, so that they can highlight what the challenges are with that. And we take out information that we've worked on, so like what Lorna was saying, and get their feedback on that and how, whether it's right and it's helping them as well. We try to speak to people most affected by health literacy. So again, earlier on in the slide, we saw what those groups were, but we're also keen to speak to everybody, because we know everybody will be affected by health literacy at some point, whether that's because of trauma, receiving bad news and things like that. I think somewhere in the chat, someone was asking about potentially work in Manchester, and we actually are using an example of best practice in Manchester, where they had teamed up with a local college to get students to give feedback on written information. So it was really positive for the students to be involved in that piece of work, and give the trust really good information. So we're using that best practice to look at how we can pilot that across our region as well. And we're linking with organisations who already do community engagement as part of their role, to understand how we can work together to make best use of everybody's time and resources. One of the big bits of our work plan was to work on patient pathways. This was one of the things to try and really make a difference across a bigger scale. So to get areas of good practice that we could roll out wider, and also help others. So to develop a tool for working on patient pathways to help others to do the same. So the work involves understanding what that patient journey is. So from a grade start to an endpoint. So it might be from the point where they're referred into a service, when they get when the GP sends them onto the hospital, to the point where they're discharged from hospital. And we would find out what's happening at the moment, so really understand every point in that patient journey, and in particular all the points of communication. So whether that's written, whether it's the letters they get, text messages, leaflets, things like that. The verbal communication, so when they're at appointments, over the telephone, also the environment, like we've mentioned before, so all the signs in the hospital and things like that. And we look at what needs to be changed. So what are the challenges? And as part of that, we involve the patients again. So we find out what you think of the information that you received as part of this journey. So already, what are the challenges, and understand from their point of view what needs to be changed. Then we make and embed the changes. So making the changes would involve rewriting the written information. So, and that would be to the standards that Lorna talked through earlier. So at the reading age of 11 or younger, and also all the different points to really simplify that information and make sure it's understandable for everybody. We deliver targeted training. So when I talk about the training we deliver as part of the pathways, we can really target the training for the team. And we observe what's happening as well. So when we're looking at what's happening at the moment, we observe some clinic appointments. We look and see what the verbal communication's like. And again, we're able to use that in the targeted training and refer back to that as examples. And then we put those changes in place. So we'll get the approval and go live with the changes, whether that's a written information, and make sure that there's we work with the team to understand how we can embed that to keep it going. So how did we choose the pathways that we worked on? one of the big things is it's important. It's good to work with people who are keen to work with us to get that buy-in from the team, so that we know that we'll have the support to be able to do the work, and hopefully the capacity in the team as well. So working with those who want to work with us, looking at things that a lot of organisations can adopt. So like you say, getting that change over a big region. We try to cover at least one part across the region, and looking at different types of organisations and thinking about what would impact the most people, and thinking about those places where we could make a lasting change. And that's the things that helped us to choose the pathways that we've worked on so far. So just to talk through a couple of the examples of the pathways that we've done. So one of the ones that we worked on was the North of Tyne bowel screening pathway, and we mapped that patient journey. So we wrote out the patient journey from the time that they get a pre-invite for their screening test, so they get a letter telling them that they're going to receive the test, through to their colonoscopy appointment if they need one. We observed the first outpatient appointment, and as part of that, we did an environmental assessment. So we took notice of how easy it was to find the department, how easy it was to check in, whether the signs matched what was on the letters and things like that. For this pathway, we focused on local documents, so things that had been developed locally as part of that patient journey that we were able to change. And these have been rewritten to the health literacy standards we've talked about, and are in use. We deliver targeted training, and we're collecting support and data to see, so that we're able to see what impact the changes have had. And we're working with the University of Sunderland to evaluate and check how well that we've done with that work. Just sharing with you a couple of the before and after examples from that pathway. So this was the before example of the low residue diet, so a low fibre diet that patients have to follow before their colonoscopy. The team had kindly kept a log of telephone calls that they received, and the majority of calls were from patients asking what low fibre meant, what low residue meant, what they could eat. It was really quite confusing what they could and couldn't eat. But if they didn't follow that low fibre diet, there was a risk that they would come on the day and they couldn't go ahead with their colonoscopy. So this was one of the documents that our editors changed, and this is the after example. So you can see it clearly highlights what patients can and can't eat, and gives them examples of that. And we're going to repeat the log of calls, just to again be able to say that has truly made a difference. But it's important again just to see what the patients think about all that. So the patients had agreed that it explained it all better. They liked the columns with the ticks and the cross, and they said it was much easier to understand. So that was really great to see. And another pathway we worked on was the FibroScan, which is a type of liver scan pilot, and that was working with County Durham Drug and Alcohol Services. So this was a new pathway, so we were involved in developing new patient information for this pathway, which included a leaflet, appointment letter, a text message, and directions to get to their appointment, and also a script for the single point of contact worker there, because they had a lot of information to go through with the patient when they first telephoned them about their appointment. We worked with the lived experience group to make sure that we got the patient information right. And again, that was great just to hear back from them in terms of, and when we talked about liver disease, they said that would scare me. I would want a word like that. When we were talking about that they would need to stop not eat before their appointment and not drink, but then if they were at risk of withdrawal, they would need to drink some alcohol, and they helped us word that in a sensitive way, but in a way that people would understand and do what was necessary for the scan to go ahead. And again, we delivered some targeted training as part of that work. And again, these are just examples of the information that was developed as part of that. And then obviously going back to the team, like I said, we've got two editors within our team, Kia and Alex, The editing has been a huge part of building up those examples of good practice and showing different examples of work written at a reading age of 11 or younger. We decided that we would accept ad hoc requests. So we knew we had to be careful in terms of capacity because it's such a huge area, but that again has really helped to promote the team and the health literacy work in general. And then also get people more and more aware of what they can do to help and improve writing themselves. We'll offer the editors work as part of the pathways as well, so those examples that we've just shown you, and the offer to support individuals when they want to write themselves. And again, it's probably a lot more than this now, but we've so far written over 80 documents have been rewritten or developed. So what else are we doing as part of our plan? One of our areas of focus at the minute is developing health literacy standards and a supporting toolkit. So we did a lot of work to understand, to look at whether we needed to develop our own standards or whether we could use existing standards. We made the decision to develop our own, and that was because some of the ones that existed were developed outside the country. They might not have been developed with people who would use them. They might not have been applicable to all different types of organisations as well. So that was a decision behind starting to develop our own standards. And we want a toolkit as well to help put those standards in place. So it might one of the standards might say you might need senior level buy-in, and this is what you can do to get that. So similar to what Lorna was talking through. So it might be a script for chief exec or senior leader video, or a template for health literacy page and things like that. We've also launched a health literacy grant scheme, which has been really really great. So this was when we gave people the opportunity to apply for some money to do health literacy work themselves, and we had loads of applicants for that. And the successful ones are underway with their projects now, and we're looking forward to seeing the output from that. And we're working with the University of Sunderland to check that our work is going well and doing what we need to. So what have we learned? So we've already seen in this webinar from the data and things like that, and the feedback from patients, that it's not something we can ignore. It's not a nice to do, it's a must do. And it makes a difference to patients. So we've seen the feedback from community engagement that they felt daunted, but then in the end they're able to follow instructions and answer questions and things like that. And people want to make a change. So again, those people coming, all the staff who we've trained so far are keen to make a difference. And that's one of the big learning things that we've found, that the importance of buy-in and being able to work with teams to make the change. We've learned that long-term culture change takes time. So it's difficult to change a culture when things have always been done in one way, and we're trying to make a complete shift to do it in a different way. And it's not just the overall culture change, it's building those examples of good practice. So the projects and the pathway work that we've talked about all take time, and there's challenges within that. So for example, there's times where we haven't been able to change written information because it hasn't been within our control. So that's another piece of work to look at that. Or there's where there's external companies involved as well, and also capacity in teams to be able to support and work on this work with us. And it's important to know what's happening now, so that we don't duplicate, and we can really build on the great work that's already happening across the country as well. So thank you very much for listening, and I'll hand over to Tracy now, who will talk to you about how to help.
Thanks very much, Emma. So I'm going to give you a quick summary and some tips and resources that you can use to really help make a change to any of your health information. And just to give you a quick overview, some of the tips that we recommend and develop and explore in our training is about encouraging people to change jargon to everyday words. That's one of the quickest and easiest way to ensure that your writing is simpler. Breaking things down into small chunks of information can really make a difference to what is sometimes really overwhelming health information, and it does make it easier to read and for everyone to digest. We've already mentioned a few times that writing needs to be at a reading age of 9 to 11 years old, and one of the quickest, easiest ways to do that is using those simple words. Getting rid of the corporate jargon is just so much more inclusive. In our speaking sessions, we explore and practice chunk and check and teach back techniques, and these really aid understanding and, of course, in turn, are better for informed decision making. And community engagement has been spoken about by Emma and Lorna, and it really is vital, asking people their preferences to the information that you already have or the information that you've rewritten at a reading age of 9 to 11. Seeking their opinions is really important, and finding out what they find useful and, of course, what they understand. So some resources that are freely available right now for you to use. One is on the e-learning for health platform. There is a health literacy module. You can create your own account here and work through the module at your own pace, and it gives you a quick overview with some really quick tips about making a difference to health literacy. You can visit our regional website, and on there you can find out what we're doing, what pathways there are shadowing, the evaluations that have taken place that have already been mentioned, and of course if there's any training available. You can, of course, reach out to your NHS Library and Knowledge Service for support, or indeed your public libraries. Your local public libraries are a really great source of trustworthy information, not just for you, but for your patients as well. Earlier on, Leanne mentioned the geodata tool, which we have used to get the statistics for health literacy levels in our area. And if you click on the literacy and numeracy combined, which is what we use because health information usually requires both skills, and then you can enter your local authority and find out where your local authority sits in relation to the national average. You can also use the NHS Medical Document Readability tool. This is a great free online tool where you can copy and paste any text onto the screen, and it will highlight any complex sentences, it will highlight any tricky words, and it'll give you an estimated reading age of that text as well. So it's a really good tool when you're starting to look at health information, and it will show you where to start rewriting at that reading age of 9 to 11 years old. There's also the A to Z of NHS health writing. This gives you lots of advice about making information easier for everyone to understand. And it includes lots of things, amongst others like punctuation or using numbers, or about design and format of your health information as well. And you can access the Future NHS platform. This is where our regional health literacy community of practice is hosted. And when you receive the recording and the slides after this event, you'll also receive a link to a video that will guide you through how to use the Future NHS platform and all the different resources and information that are available on there. And you can join the community of practice as well. So some of the training that we have developed and delivered over the last year, one is our health literacy awareness training, and it is every month, both online and face-to-face, and it gives you an overview about what health literacy is and the impact it has, and introduces very quickly what you can do about it or what you can do to address it within your workplace. We've also developed and deliver some skills training. So we've got how to write simply and speaking simply. And again, these are monthly, and they delve much deeper into the techniques, and we use real examples of written and spoken information and the revised versions. And we also give attendees a time to have a go. And we have developed master skills training as well, and started to deliver these for our communications teams regionally. And the master skills training gives much more theory into why the changes are being put in place And we also give much more practical time for people to have a go at rewriting information alongside some support. And we do some training around the checklist and the guidance that needs to be followed so that people can start to use that health literacy watermark that Lorna touched on earlier. And this obviously identifies that any document has been through the health literacy process. And so Leanne asked you right at the very beginning of the webinar to rate your health literacy knowledge on a scale of 1 to 10. So I'm going to ask you to do that now. Given the information that we have all gone through regionally on a trust level, the impact that it has, what's your knowledge now with regards to health literacy, with 1 being not so much, 10 being expert? And whilst people are giving themselves a grade or a score of 1 to 10, I'll just repeat what was said right at the very beginning of the webinar, that if we haven't managed to address or answer any of your questions or queries throughout this webinar, we will come back to them and a summary will be sent out with the recording and the slides. Okay, so you've heard what we have done on a trust level and what we have done on a regional level. So we're now just wondering, what will you do with this new knowledge, this information, the ideas that you've had from us? Just pop any ideas into the poll now, and we can just take a little snapshot of what people think they can do or what they would like to do. And we've got some great responses now popping up. Share with my team, look at leaflets, share the resources, review materials. This is brilliant. That sharing of knowledge, I think, is key. The sharing of the impact that health literacy has, and indeed, as we've all discussed, what we can do about it. And reviewing your own materials is a great place to start. And speaking to your patients and your service users, as we said before. And Emma did touch on the fact that we're developing some standards and a toolkit, and a QR code and a link in the Q&A has already been shared for people to complete a quick survey about what you would need to put this into practice, or what support would be required. Just to help us generate something that's really meaningful and useful for everybody. So in summary, we have a quick evaluation for you. And again, some questions are going to pop up in the poll. Just for you to answer about everything that you've heard today, and how satisfied you were. Did it meet your expectations? So firstly, how did you find this webinar? Very dissatisfied or very satisfied? Just to give yourself a number of stars, and click the submit button. Thank you. And the next question is around what were you expecting to hear from today? So did the event and the agenda that you were sent meet your expectations? If you don't have access to the polls, these questions are available in the chat as well. And then finally, if you could share any of your top 3 highlights, that would be great. Anything that you have found inspirational, or anything that you want to, share again with colleagues. Practical examples, yeah, we often find that's really useful. That's why we always use practical, real examples in our training. People need to see the techniques and the skills that we're sharing put into practice. Case studies is really good. Yeah, the reading age is shocking, but there is something that we can do about it. And examples of solutions, yeah, solutions is a great one. And the tools, of course, start using the tools all the time now. Everything that I've spoken about now and everything that we have shared today is freely available. And so again, just a reminder that there is a quick questionnaire for you to complete about what support you would need to make some changes within your workplace. And without further ado, I will just pass you back to Ryan.
Thank you, Tracy. Thanks, everyone. That was great. And we're slightly ahead of time, which is brilliant. I was worried we might run out of time. So I just wanted to wrap up a little bit and say a few thank yous. I think it might have been Lorna touched on, this work is potentially a bit boring. I would encourage everybody to get on board with that. Some of this stuff is straightforward. It's not new and shiny and sexy, but it does make a real difference. It's something that everybody can do something about. So I'd encourage everybody, when you leave here today, to think about what will you do differently. I think there are tangible steps that everybody can take. Please do get in touch. I think our contact details have been shared throughout the slides. Please do get in touch. We'd love to carry on some of the conversations that have started in the chat today, and to think about how we can work with partners in different bits of the country. Final thanks, all of you. There's still almost 500 of you on. We had about 640 at one point, so just thanks very much for taking the time. Thank you to the team for all their hard work on this, and to our partners at Health Innovation North East North Cumbria, who've helped put this on for us today and have been a huge support. Thanks also to NHS England for asking us to do this and being part of it. And of course, thanks very much to the ICB here in the North East and North Cumbria and the Trust at South Tyneside and Sunderland for supporting this work. I hope it's been useful. I've got 6 minutes. And I'm nervous about opening that up to questions because I worry we won't get through any. We will certainly try and get back to everybody. I think we've tried to answer most of the questions in the chat function, but what we'll do is collate all of those responses and the ones from the earlier webinar and send them out to everybody so that you can all see all of the questions that were asked and all of the responses. If you still have further questions after that, then do get back in touch. We're more than happy to carry on this conversation outside of there. But with 5 minutes to go, I think I'm going to suggest that we call time there, give everybody a chance for a cup of tea before their next meeting. Thanks very much, everybody. It's been great to have you all with us. Thank you.